Hello everyone, my name is Olivia Clayton and I'm the Manager of Healthy Start, which is a national strategy that aims to improve health and wellbeing outcomes for children whose parents have learning difficulties. We are thrilled to be able to bring you a speaker all the way from Sweden today, which really isn't that difficult now that we have this sort of technology. The only thing is that right now it is midnight in Sweden, so we have pre-recorded the presentation last week to play for you today. I'm speaking live now, and at the end of the 20-minute recording that I will play in a moment, we'll conduct a live Q&A session as per usual, but with Cherise Smith, the coordinator of the Women with Individual Needs Clinic at the Royal Women's Hospital in Melbourne, as our guest Q&A practitioner. So for those of you who are not familiar with Healthy Start, webinars are just one part of what we do. We also provide summaries of latest research on our website. We have there also best practice information around certain topics. We call these practice points. And just general information about evidence-based resources for working with parents with learning difficulties and how to access these. We also host an online practice network where members can share knowledge, join groups or co-develop ideas, and there will be a recording of this webinar uploaded onto the online network this afternoon. And our guest will be there in the next day to respond to any direct questions for her. And another part of Healthy Start is that we also run face-to-face forums and workshops. So essentially, we work to build the capacity of individuals and agencies to address the needs of parents with learning difficulties in their area, using research and working through it to fit it to their context. Now, just some quick housekeeping before we begin. If you're having any technical difficulties, please call Laura Nicholson for support on 03 8660 3538. Her details are also just popping up now in your GoToWebinar control panel. So to ask a question throughout any part of the presentation, which as I mentioned will be answered by Cherise Smith of the Women's at the end, just click on this control panel for GoToWebinar and you'll see a box where you can post questions. So please submit a question here anytime. The presentation will go for approximately 20 minutes and at the end I'll pick out some of the questions you've posted for Cherise to respond to, and questions for our guest speaker should be posted or will be posted on the online network where both a recording and the discussion will be this afternoon. So if you're not a member yet, I encourage you to sign up. Now just finally, at the commencement of question time, a webinar evaluation survey will appear on your screen. Please fill this out. It should only take 2 to 3 minutes. All right, so what's this webinar all about? Well, having a baby and becoming a mother is, for many women, an exciting time of life. And like other women, women with learning difficulties often delight in their pregnant bodies and the baby growing within them. Some mothers talk about feeling connected to their baby from the moment it's conceived. For others, that feeling grows as the baby develops. The stories women with learning difficulties tell of their experiences as pregnant women and as new mothers are often no different to any other woman expecting a baby. However, other people in the lives of these women often treat pregnancy as a grave mistake, and so they face significant opposition to their pregnancies, including pressure to abort, both from their families, their friends, and the services that are there to support them. So, why does this matter? Well, Australian research from the last 10 years tells us that women with learning difficulties and their babies are at greater risk of poor health outcomes during pregnancy and the early postpartum period. So this tells us that quality care is paramount in the antenatal period to give these mothers and their newborn babies the best start in life. Studies from the University of Sydney have indicated that women with learning difficulties are significantly more likely than other pregnant women to experience preeclampsia, have babies with a low birth weight, have their baby admitted to neonatal intensive care or special nursery, and experience adverse mental health outcomes such as depression, anxiety and stress. So lack of access to information is a top concern for these women. And Brenda Bergen from Monash Uni and also from the Women's in Melbourne examined 20 records of women with cognitive impairment who report unplanned or unwanted pregnancies to the Pregnancy Advisory Service in Melbourne. 18 of these women had intellectual disabilities and 2 had acquired brain injuries. So compared to women without cognitive impairments, the women with cognitive impairment tended to be younger, tended to recognise their pregnancies later, and tended to recognise pregnancies too late for abortion. The conclusions from this study were that it's crucial to provide accessible information on sexual and reproductive health to women throughout their reproductive years, and that the approach is both proactive and supportive. Now, before we listen to what our presenter has to say on this topic, let's have a quick look at who is here. Well, we had 75 people register for this webinar and a real mix of different roles. You can see there our largest numbers of registration are in the lighter grey. Those are program coordinators and management roles, so that's great to see. The darker grey shows that a large contingent of people are from allied health fields, so OTs, psychologists, social workers, speech pathologists and physios. And the light blue includes those practitioners who identify as providing direct parenting support. Good to see that the invite got also to a fair proportion of those in nursing and midwifery. That's the yellow chunk there. However, despite some wide publicity, we have not had many obstetricians or GPs register, so perhaps those who are here today can circulate the recording to their health networks. Now, we're interested in why you joined this webinar today, and so have a quick live poll for you to respond to now. Which of the following motivated you to join today? To hear about these particular studies from Sweden, just for general information for pregnancy and birth support, or just general information on parents with learning difficulties, or something else? Great, almost 90% of you have voted, so I'm going to close the poll now. That is great feedback for us. So a few of you are here because you are interested in these particular studies. You'll hopefully get a lot out of this presentation. Those of you who are here for general information for pregnancy and birth support, you too will find the presentation a good way to get a solid understanding of the latest research in the area. And also I'll let you know that I will be talking through some of the further information and resources that Healthy Start has on supporting parents with learning difficulties during and after pregnancy before we finish today. Now, for those of you, a large chunk of you who are here for general information on parents with learning difficulties, this webinar obviously won't cover all that you're wanting, but a great place to read more about best practice with parents with learning difficulties is to have a sift through the resources section of our website, particularly our practice points, and you may like to watch a number of our videos in the videos section of the Online Practice Network. But please also feel free to contact me directly. So now I'd like to introduce our guest speaker. Berit Höglund is a registered nurse and midwife. For nearly 30 years she worked as a midwife at the delivery ward in antenatal care and with family planning. It was in the 1990s that she became interested in midwifery care for women with intellectual disability. In the early 2000s, Berit received a master's degree in medical science, and this led to further studies and completing her doctorate in this area at the Department of Women's and Children's Health at Uppsala University in Sweden. So the overall aim of Berit's PhD was to investigate pregnancy and childbirth in women with intellectual disability and the health of their newborns in Sweden. And for the next 20 minutes, Berit will talk through her findings and her recommendations for ways to improve services. And then we will come back to a live Q&A with Cherise Smith from the Women's in Melbourne. So just bear with me a few seconds while I press play on the recording.
Hello, everybody. First of all, I want to thank you for having invited me to participate as a guest speaker of this webinar at Healthy Start. At this map, we can see the big distance between Sweden and Australia. Despite of that, I have had the great pleasure to visit Australia at 3 times. The places I have visited are blue marked. So, my name is Berit Höglund, and I am a registered midwife, researching nurse and midwife, and a doctor of philosophy at Uppsala University. Here you can see the main building of university in late autumn. The title of this web seminar is Insights from Sweden, Enhanced Care and Support During Pregnancy and Birth for Women with Intellectual Disability. My entrance to this research area belonged to the 1990s. Then I met several women with intellectual disability when they delivered their children at a delivery ward. At these times I wondered several things as, does she understand the delivery process? Does she express her needs in the same way as women without intellectual disability? Do I underestimate her needs of care during delivery as pain reliefs? Is she trusting me? I tried to find out the answers in medical sciences, but I found few papers who highlighted and answered these questions. In my own previous education, I have never got any special knowledge about women with intellectual disability in pregnancy and childbirth. The questions were growing in my head, and after some years I became a doctoral student, which ended with my dissertation last year. Now I work as a lecturer in the midwife program, and half the time I continue to research in this area at Uppsala University. An interesting question to raise is, how much do we know about pregnancy and delivery among women with intellectual disability and the newborn health in their children? And now I will go further to present the 2 studies. The first is Pregnancy and Birth Outcomes of Women with Intellectual Disability in Sweden, a national register study, which is about the pregnancy and delivery outcomes. The second, newborns of mothers with intellectual disability have a higher risk of perinatal death and being small for gestational age, describes the children's newborn health. These studies are published at the Journal of Obstetricia and Gynecologica Scandinavica. The definition of intellectual disability with a reference to World Health Organization imply an intelligence quotient less than 70, a derogation of adaptive capacity, and a debut before 18 years of age. With less adaptive capacity means less academic skills as read, write, and count, less practical skills in daily active living, and less skills to cope in social situations. The aims in study 1 and 2 were to describe pregnancy and delivery outcomes among women with intellectual disability and newborn health in their children compared to women without intellectual disability and their children. The study was carried out on a Swedish population-based cohort of women with intellectual disability in ICD-8 to ICD-10 and a cohort of women without intellectual disability or any psychiatric diagnosis. The women were identified from the National Patient Register linked to the Medical Birth Register at the National Board of Health and Welfare, from which the control group was also selected. The samples were based on diagnosis from hospital and non-institutional care and medical records from pregnancy and delivery between 1973 and 2007 for the whole of Sweden. The Medical Birth Register covers 98 to 99% of all births and compiles information related to antenatal and perinatal factors that could be of importance for the health of the child. A more stringent cohort was chosen for analysis with only primiparas and singletons between 1999 to 2007. So this resulted in 326 women with intellectual disability and their children, and 340,624 women without intellectual disability or other psychiatric diagnosis and their children concerning pregnancy, delivery outcomes, and newborn health. The results in paper 1 showed several differences between women with intellectual disability and women without intellectual disability during pregnancy and delivery. During pregnancy, women with intellectual disability were on average 4 years younger than women without intellectual disability, 24 and 28 respectively. The proportion of teenage births between 11 to 19 years was higher in women with intellectual disability, 18%, than in women without intellectual disability, 3%. The mean of body mass index was 25 and 24, respectively. Further results in socio-demographic and maternal health in women with intellectual disability compared to women without intellectual disability at registration were more than 1/4, 28%, in the women with intellectual disability smoked compared with 8% of women without intellectual disability. More than 1/3 did not cohabiting with their father, 37% versus 6% in women without intellectual disability. more than one-half of women with intellectual disability was not working, 54% versus 14% in women without intellectual disability. The women with intellectual disability had almost 14 times higher proportion of epilepsy than women without intellectual disability. The women with intellectual disability had more often preterm birth, which means a birth before 37 weeks full gestation, 12% versus 6%. And we saw also that preterm birth were constant over time. The deliveries ended more often with cesarean section for women with intellectual disability compared to women without intellectual disability, 25% and 18% respectively. Further used these women less nitrous oxide during delivery, 60% versus 76%, and they had a higher proportion not to be discharged directly to home, 7% versus 2%. At logistic regression analysis, the crude odds ratio affirmed for all the 4 outcomes: preterm birth, cesarean section, non-use of nitrous oxide, and discharge to other place than home, had a correlation to women with intellectual disability. This correlation remained after adjusting for maternal age, obesity, smoking, cohabitation, working, and epilepsy. The children born to mothers with intellectual disability compared to children born to mothers without intellectual disability were born preterm before 37 full gestation weeks with 12% versus 6%. It was 4 times more often that children born to mothers with intellectual disability were stillborn, 1.2% versus 0.3%, and 4 to 5 times more often they died a perinatal death, 1.8% compared to 0.4%. This data set included the perinatal death between 28 weeks full of gestation to 1 week postpartum. Further was 8% of the children born to mothers with intellectual disability small for gestational age, which means a birth weight less than 2 standard deviations below the mean weight for gestational age and gender. They were more often born with cesarean section, 25% versus 18%, and had an Acta score less 7 at 1 and 5 minutes, 10% versus 6%, and 4% versus 2%. The Acta score is a method which describes the condition of a newborn health at 1, 5, and 10 minutes after birth. In this assessment, 5 parameters are included, which amount to 10 points. A logistic regression analysis affirmed that crude odds ratio to all the 5 outcomes, premature birth, Acta less 7 points at 5 minutes, small for gestational age, perinatal death and stillbirth, had a correlation to women with intellectual disability. After adjusting for maternal age, obesity, smoking, cohabitation, working, cesarean section and epilepsy, the correlation remained between the mother's diagnosis, intellectual disability, and small-for-gestational age, perinatal death, and stillbirth. The conclusions of paper 1 and 2 are that women with intellectual disability and their unborn and newborn children have more complications and should be regarded as risk groups. Further, that caregivers need to be aware of these risk groups and provide better tailored pre, intra, and postpartum care and support. Based on the results, I want to suggest following development and measure within care: more visits and enhanced time with a midwife, support with interactive methods and improved parent education. Additional suggestions are better individualized pregnancy and labor care, better interpretation and response of labor pain, and increased competence for the midwife and better support to midwives. At last, I want to show the front page of an interactive brochure called Waiting and Deliver a Child and to Take Care of Your Child the First Time, a brochure to be a parent, which is performed at the midwife program at Uppsala University. This brochure is adapted to women with intellectual disability and other cognitive limitations and to women who have not the Swedish mother tongue. This brochure is more and more used at antenatal care in Sweden and includes 3 parts: the pregnancy and the delivery, and how to take care of the child the first time at home. When the midwife at antenatal care is meeting a pregnant woman with intellectual disability, she is uploading this brochure from the website on the slide. The woman owns this brochure herself. She is taking it with her every visit to the midwife at antenatal care and working together slowly and with security through this during pregnancy. The brochure is basic and easy to read with big letters, many photos and illustrations. The brochure urges to work interacting with different events and situations. Both the woman and the midwife can read, write, point in this brochure. An important thing to do at every visit is to repeat previous parts of the brochures. It is good for the woman to have her own brochure at home so she can look, read, think, discuss, alone or with her partner, relatives and/or friends whenever she wants. When the child is born, she continues to work interacting with the brochure and with the children's nurse at the Child Welfare Center. This brochure is inspired and based on Healthy Start for Me and My Baby. With this last slide on the statue called Maternity, as you can find in Semmelweis Garden in the capital of Hungary, Budapest, I want to thank you for your attention. Thank you.
Thank you very much to Berit for her presentation. So now for a Q&A time. In this webinar we have Cherise Smith from the WIN Clinic at the Royal Women's Hospital. If you haven't posted your question yet already, please do so in your GoToWebinar control panel. So just a quick introduction to Cherise and the WIN Clinic. The WIN Clinic has provided antenatal care for women with an intellectual disability or learning difficulties since 2003. The clinic can also work with women who have acquired brain injury, physical disability or sensory impairment who are pregnant. Now, if you'd like some more information about the WIN Clinic and how it works, you, I'm sure, can ask Cherise now, or you can watch our first ever Healthy Start webinar, which was presented by Cherise on the WIN Clinic in 2012. Now, let me just unmute you, Cherise, so that we can hear you. Can you hear me, Cherise?
Yes, I can.
Hi, welcome. Did you have any opening comments you wanted to make about Berit's presentation?
It was wonderful to hear her presentation, and it actually is quite reassuring because there's research that has come out from her study, or the information from her study actually supports what we do in our clinic and the reasoning behind what we do in our clinic. So that's fabulous that we are continuing to support the women that need this extra support.
Yeah, great. Now, let me just pick out a couple of the questions for you to have a crack at responding to. And then if anyone does have any questions that we don't have time to answer today, or that they'd be better suited to be answered by Berit herself, then I'll post them on the Online Practice Network, or please, by all means, you can go on and sign up to the network if you're not a member already and post questions there. Now, a question about wondering if there's any similar findings in Australia about this as a high-risk group, and where can you find out more? Well, I might just first mention an answer to that would be to have a read through our research summary on this topic on the Healthy Start website. We try very hard to translate research into easy to read, straightforward documents that can be downloaded from our website. But also, if anyone's interested in more research, welcome to contact me, and I can try and point out some particular authors that might be useful to have a read of. Did you have anything else you wanted to say about findings from the WIN Clinic or your own research, Cherise?
Well, in regards to the research that was done in Sydney, you mentioned at the start of the webinar, at round about the same time that did come out, I myself looked at some of the women that were coming through our clinic, and our data supported exactly the same as what that research at Sydney was findings were, and it does seem as well that Berit's research also has come up with pretty much the same sort of findings. So that's really interesting. Yeah.
What are the key ones?
The low birth weight, more incidence of PE, preterm labour, and more likely to be induced and have cesarean sections. That type of information. We have found that definitely the clientele coming through our clinic have the same issues, as I said, as opposed to that, same issues as that Sydney study findings were and Berit's findings. So despite even having like a clinic that's, I guess, set up especially for women with intellectual disabilities or disabilities, you know, we still know that that's the sort of clientele that we're having come through the clinic. So it's about supporting them, knowing that they're a high-risk group, and being quite aware and tailoring your care to that risk.
Yeah. A bit more of a practice question for you from one of our attendees, Cherise, which is how does one manage women with intellectual disability who do not want to identify as having an intellectual disability?
Well, I think just generally, you know, when, you know, caring for the women, I generally just care for the women with the view that they have more needs, not what their disability is, just in regard to looking at what are some of the barriers that they're facing, what are some of their general health issues that they have, regardless of whether they've got a disability or not, and what type of disability it is. Looking more at how can we overcome the barriers, how can we, treat this particular issue that the woman has, and whether you would do that with every woman that comes through, regardless if they've got a disability or not. So it's, you don't have to say you've got a disability, this is what we need to do for you. It's just that these are your issues as a person, and this is how we need to address them.
And does that work well at the women's in that respect?
Well, absolutely, through this clinic, because we actually are, have that expertise in basically being aware of what their extra needs are. So by having that expertise in the area, you already have got that background knowledge when you're caring for these women. So you're not having to spell it out as much like what, you're sort of anticipating some of their needs, I guess, so that it makes the care a little bit less intrusive of actually having to, identify every issue that they may have. We know that with disability, intellectual disability, that they do have high risk factors, and so we're looking at, we already know that, so we're caring for them with that background knowledge and working with the women themselves and asking them, identifying with them what they feel they may have need extra support with. So including them with the care and with our knowledge as well combined, I think it sort of provides a more, as I said, more specific and tailored care to those women.
Good. Well, this next one asks really just for, I guess, your opinion, Cherise, and others out there might also have an opinion on this that we could continue discussing in the online discussion. But Margaret says, to date we have argued that having intellectual disability should not be a risk factor in child protection. So do you think it should be in prenatal notification? And if so, does this raise, what sort of implications does this raise for child protection outcomes for these mothers and their children?
I think every individual case should be taken on its own merit and taken as an individual case. Just because you have a disability doesn't mean that you're going to be a poor parent. It just means that you may have lesser support systems in the community, and once again it's just looking at the individual person, regardless of whether they've got a disability or not, and what their support needs are, and trying to implement those. Yeah. And yes, I guess would say unfortunately there are probably situations where child protection notifications are done, but as I said, generally just looking, I don't think just because you've got a disability you should be, highlighted. It's more on an individual basis rather than does she have a disability or not. Because it varies so much. Disability varies so much. So, some people, have very good support systems already in place and others don't. And it's just about filling those gaps of where they need that support.
And following on from Margaret's question, there's a question wondering if the WIN Clinic has formal networks with child protection services and other health services that you work with.
Not when you say formal networks, what do you actually mean by formal networks? Yeah.
Well, that's what the question says. So maybe we'll take that as relationships with child protection.
I don't think. I think we just work with that service, as I say, as we feel we need to. But I think we advocate for having, that, once again, that expertise in disability and knowing that there is some prejudice out there in regards to disability and ability to parent. We're able to advocate for the women to help support them through that process, if that is, is the process that ends up happening.
Yeah. Actually, Kate's just clarified what she meant by formal networks. She meant any established communication pathways with child protection.
As in, like, if we know someone's got a disability, it's just given that we notify. I'm not exactly still sure. Like, as I said, we just look at the individual case, and if there are significant concerns, and we've approached the woman and tried to put those supports in place, or if supports are just not available, then regardless of who the woman was, whether they had a disability or not. They, sometimes, unfortunately, notifications do need to be placed, but we don't have a system where someone's already got a disability, then we automatically do a pre-birth notification or anything. Not at all.
Good. Well, just one last question for you, Cherise, because I did want to spend just a couple of minutes showing people who have been asking about that resource that Berit spoke about. I wanted to show how they can get that through Healthy Start.
Yeah, absolutely. Yeah.
The last question I've got is thank you, Jane, for posting this question again. It's just a question about what are the typical, if there's typical, discharge arrangements for women who have an intellectual disability?
I think as I say, once again, that's why we call it the Women's Individual Needs Clinic, because we look at each woman on an individual basis and their specific needs. We do have, generally speaking, longer stay for women with intellectual disabilities so that they have more time to work with the midwives and learn skills to parent their baby independently when they leave the hospital. And we have worked closely with the women throughout the pregnancy in that antenatal period, having more regular visits and longer visits, so that appropriate discharge plan can be put in place in regards to linkages with community supports, etc., so that when they are ready for discharge, it isn't like a crisis situation. Everything's been put in place and more likely to be a smoother transition from hospital to home. And we also continue through our clinic to do outreach once a week for 6 weeks. And myself as the midwife, that smooth transition while other community services are being linked in, and the women are getting used to those new services and workers that they'll be working with, rather than just discharging them and having this sort of gap of no one really linked in, no one really knowing to the woman. By us helping that transition, I think really does help the women staying involved with them for that 6 weeks postnatal.
Yeah, great. Oh, well, thank you, Cherise. I'm going to spend the last couple of minutes just talking about where to find more information about research, which people are asking about, and the resources that we have. So I really appreciate your time. And can people continue discussion with you on that online discussion as well? Would you answer further questions? That would be great.
Yeah. How do I get into that?
I will send you an email. I will send you an email.
Great.
All right. And everyone else, you will also get an email showing you how to join that online discussion, access the recording, post questions this afternoon. All right. So just to finish up today, I wanted to talk about that brochure that Berit mentioned. Or it's really a booklet that's available for women with intellectual disability in Sweden. And that Swedish version was based on Healthy Start's Me and My Baby resource, which is on your screen now. So Me and My Baby promotes the health and well-being of pregnant women with learning difficulties during pregnancy and childbirth and postnatal. So it includes a book for pregnant women with learning difficulties who use it in consultation with their midwife or pregnancy care worker at home or in the clinic. And the package includes a guide for practitioners. So I've just included a few screen grabs here of the resource. You can see that it has space for important information, followed by chapters on things such as changes to expect in you and your baby, health and looking after yourself during pregnancy, labour and birth, what to expect when going home, and then postnatal care. So just a few more shots from inside the resource here. I mean, it includes really essential information with illustrations and photographs, questions that women might like to ask their doctor or midwife, and tip sheets. It encourages women to use the workbook to document any changes that they've noticed. An evaluation of this resource showed that both pregnant women with learning difficulties and practitioners found the resource to be unique and accessible and useful. So if you are interested in this resource, please contact us. And the last last resource I thought worth showing through Healthy Start also is the Step-by-Step Baby Care DVD. So this DVD can be used as an interactive teaching aid and left with parents to use at home. The skills are broken down into step-by-step components with repetition and prompts to direct the viewer's attention to the most important parts of each skill. And the skills that are demonstrated in the video are based on feedback from parents with learning difficulties who identified the skills they found most difficult to learn. So the DVD shows parents how to perform cleaning and sterilising baby bottles, making up a bottle using infant formula, washing your baby without a bath, and giving your baby a bath. Again, please just contact us through our email for these resources. So that's all for today. We've just gone a minute over time. I'll finish up. A reminder that we will post the recording of the webinar on the discussion page this afternoon, and you'll receive an email when it's live with a link to view and a link to the discussion forum where you can post questions for Berit and Cherise to respond to over the next few days. So if you're not a member, please sign up. And thank you all very much for your attention, and we would very much appreciate your feedback via the webinar evaluation survey that will appear on your screen in a few seconds. Other than that, have a great day, and I hope to hear from some of you soon.